GDM, the risk factor for future diabetes mellitus and cardiovascular disease. I firmly believe this is the truest sentence, and where all the metabolic disorders starts. They kick off here only, and this is the only place where we can prevent all cardiovascular disease as well as metabolic disorders, including diabetes and dyslipidemia and other as well. So Indian women are always at higher risk due to their phenotype, due to their uh, uh, genetic status. So rate of gestational diabetes in comparison to non-Hispanic white women, in Indian Asian women, it is very high. So hyperglycemia in pregnancy overall in women between 20 to 50 years of age, according to IDF region 2017, though I have not put the recent data, which is more striking and which says that 1 in 6 live births occur to women in some form of hyperglycemia, and among them, 84% are due to gestational diabetes. It is not pre-existing diabetes, though in recent data, it is showing that pre-existing diabetes is also increasing in hyperglycemia in pregnancy overall. So global statistics suggest that the IDF data shows regional variation in hyperglycemia during pregnancy across different geographical area. So GDM as a whole, if we see according to this 2007 paper by Carpenter, it shows that GDM is in stage of evolution of type 2 diabetes. So pancreatic beta cells are at stress when a pregnant woman gets conceived, and from there only it is stress test for beta cell of pancreas. So GDM represents the detection of chronic beta cell dysfunction. So a woman, if she is developing gestational diabetes, that it means that her pancreatic beta cells are in chronic dysfunction. And this wonderful paper from Tatiana Radeli showed that gestational diabetes induces placental genes for chronic stress and inflammatory pathways. So as this sentence says everything, we know that chronic inflammatory pathways and stress due to genes uh, uh, means everything, and hereby insulin resistance increases. So placental interference, inflammatory response, and molecular pathways, this all things increases stress and inflammation in women body when they develop gestational diabetes. So as a new natural interference between mother and fetus, the placenta is the obligatory target of such environmental changes. GDM elicits major changes in expression of profile of placental genes with prominent increase in markers and mediators of inflammation and regulation of this inflammatory pathways like IL, that is interleukins and leptin and tumor necrosis factor alpha receptor, as well as downstream of molecular adapters, indicates an activation of pathway recruiting stress activated protein. So lifetime risk of type 2 diabetes increase in women with gestational diabetes. Up to 50% of gestational women, gestational diabetic women develop IGT within 5 to 10 years. So this is quite striking. They develop pre-diabetes within 5 to 10 years at least. Almost 50%. So ADA 2021, women with GDM have 10-fold increased risk of development of type 2 diabetes than in non-gestational diabetes. So GDM increases the risk of type 2 diabetes by 10-fold in comparison to non-diabetic. So here they have given year by years, decade by decade, how many percentage of women develops impaired glucose tolerance. This is what 2009 paper has shown. So gestational diabetes may play a crucial role in increasing prevalence of diabetes as well as obesity. So it is the origin of cardiometabolic disorder. It is shown by multiple papers. One of them is very important, which says that gestational diabetes mellitus and future cardiometabolic or cardiovascular risk This paper was published in 2016, and then among what they have shown is that gestational diabetes causes insulin resistance. Ultimately, it leads to inflammation, hypertensive disorder, endothelial dysfunction. Type 2 diabetes increases cardiovascular diseases, obesity and metabolic syndrome, dyslipidemia, genetic and epigenetic factors plays a vital role in developing cardiovascular diseases as well as metabolic disorder. Another few studies in 2009 and 13, they showed that women with GDM are at higher risk of premature cardiovascular disease. So women with history of gestational diabetes has higher prevalence of metabolic syndrome as well as increased risk of cardiovascular disease. This paper was published in 2009 by Ravi Ratnakaran from Canada. Over 10 years, women with gestational diabetes, a more non-invasive cardiovascular diagnostic procedure, simple cardiovascular events and total cardiovascular hospitalization after adjusting for age, ethnicity, and comorbidities such as preeclampsia and even obesity. This paper was published in 2013. One of the important study was cardia study. This cardia study was published in 2021, and it showed that gestational diabetes history and glucose tolerance after pregnancy associated with coronary artery calcium in women during midlife. So women without previous gestational diabetes showed a graded increase in risk of coronary artery calcium association with worsening glucose tolerance. But the women with gestational diabetes had 2 times higher risk of coronary artery calcium score across all subsequent levels of glucose tolerance. So even after controlling blood sugar, it increases coronary artery calcium score in women who had previous gestational diabetes. So even after normoglycemia in women with gestational diabetes, it does not correct. So itself it increases coronary artery calcium score in women who had history of gestational diabetes. Gestational diabetes and long-term cardiovascular risk factor. This study was published in PubMed and in association with gestational diabetes mellitus with overall type specific cardiovascular and cerebrovascular disease. This was systematic and meta-analysis, and it showed that concerning links between gestational diabetes and future heart disease. Women with gestational history face significantly elevated cardiovascular risk throughout their lives. So it showed in another meta-analysis and that there is 45% increased cardiovascular risk compared to women without GDM history. 1.7 times higher risk of heart attack risk, myocardial infarction risk, 1.6% higher risk of heart failure, and 1.4 times higher risk of cerebrovascular disease, including stroke risk. So evidence from large-scale studies like Canadian nationwide study, UK biobank study, and cardia study, they all showed that nearly double cardiovascular disease event rate at 10 years, higher incidence of heart attacks, so myocardial infarction, heart failure, and arrhythmia in patients who had gestational diabetes. And I already talked about cardia study where it showed coronary artery calcium score was 20% higher in who had GDM history. So prospective study consistently demonstrated 1.5 to 2-fold increase in long-term cardiovascular disease risk. So metabolic pathway to heart disease, where it says that if a woman has gestational diabetes history and initial pregnancy complication, it increases metabolic syndrome by 3.74 fold higher. Type 2 diabetes, which is around 8 times higher risk development, and cardiovascular disease higher by many fold with myocardial infarction, stroke, and heart failure. So GDM triggers cascading metabolic disorder. Over 50% develop diabetes within 10 to 20 years. This is again this about cardiac study that what I explained, that even women who had normoglycemia after gestational diabetes, but their risk of coronary artery calcium score continues. So what are the clinical implications? Sustained normoglycemia is the limitation. Sustained normoglycemia among women with previous gestational diabetes may not diminish future atherosclerotic cardiovascular disease risk in women during midlife. So prevent GDM is the option, but not preventing cardiovascular disease after GDM is an option. Underlying vascular changes, where a history of gestational diabetes may entail underlying vascular changes and adversely affect development of cardiovascular disease through pathways such as insulin resistance, impaired insulin secretion that promote atherogenic plaque independent of dysglycemia. Enhanced screening needed. So during pregnancy only, if you can control this hyperglycemia and dysglycemia, that could be helpful. So these findings add to mounting evidence that enhanced cardiovascular disease risk factor screening among women with history of gestational diabetes is needed to better risk stratify women for early atherosclerotic cardiovascular disease prevention. Also, so the clinical implication and prevention, where early identification of GDM, which serves as early marker of future cardiovascular risk requiring vigilant monitoring, aggressive management during pregnancy and not after pregnancy, that if you can correct hyperglycemia after pregnancy, it is not helpful. So monitor blood pressure, weight, lipids, and glucose levels to prevent disease progression, as well as risk calculator gap, which majorly cardiovascular disease calculator rarely include gestational diabetes, potentially underestimating lifetime risk. So only 23% of GDM and cardiovascular disease association explained by diabetes progression. Other factors drive excess risk. So prevention and screening is the key, where early detection, regular screening of cardiovascular disease, as well as risk assessment for cardiovascular disease, comprehensive evaluation of multiple risk factors, intervention where targeted prevention strategies and lifestyle modification is important, along with monitoring, where ongoing surveillance and follow-up care is also important. So female gender, the key of diabetes prevention, where Lysy Kingo says that low birth weight or even high birth weight with large for gestational age birth weight, they have intergenerational transfer to the risk and maternal health, which ultimately lead to link of different kind of non-communicable diseases. So low birth weight as well as high birth weight, both are related to elevated risk of obesity, cardiovascular disease, and diabetes, which ultimately goes to another generation in female, especially the female child who is born to gestational diabetic mother has higher chances, and she is going to pass this genes as well as this disease risk to next generation as well. So intergenerational risk factor is there, and father of gestational diabetes, David Barker, said that the body's susceptibility to lifestyle disease was programmed intrauterine. So during this pregnancy only, everything is programmed, and if you don't control at this point of time, it is really difficult. So it's a vicious cycle where gestational diabetes and overweight frequently affect the same people, and causality is bidirectional. So obesity lies on the causal pathway towards hyperglycemia, and hyperglycemia in pregnancy is causal related to obesity in offsprings. So it passes in intergenerational or transgenerational transmission of this cardiovascular disease. Also, hyperglycemia may well exist before pregnancy, as demonstrated by large surveys as NHANES. So obesity leads to hyperglycemia in pregnancy, it leads to obesity in future generation, and those obese children are again prone to diabetes. So breaking cycle is very important. So the womb is the first place where legacy starts, and so it depends on us what legacy we want to pass to our next generations. With this, I'll conclude that prevention is the key and early intervention saves the life and future generation by breaking the cycle for our children of for GDM as well as it again we can stop passing this metabolic disorder like obesity, cardiovascular disease, and healthcare excellence is needed for this thing. So advancing maternal and cardiovascular health is important to prevent this future generational cardiovascular disease and metabolic disorder transmission. With this, I'll conclude my talk.